Good morning. Let's discuss the questions of ophthalmology asked in AIIMS June session for this year. The first question: visual field defects are seen in vigabatrin, ethosuximide, levetiracetam, and phenobarbital. So this was a fact-based question, and the answer straight away is vigabatrin. So let us look at a few characteristic features of vigabatrin. It causes an irreversible retinal dysfunction, which leads to a permanent bilateral concentric visual field constriction. The diminution of vision is often asymptomatic, with the patient having a normal visual acuity as well as color vision. And the reason why the patient has asymptomatic visual loss is because this damage happens more in the periphery, and first in the periphery and last at the center. So when the retinal damage is more at the periphery, the patient does not feel the symptoms as early. This onset of vision loss can occur within weeks, months, or years of starting treatment. In short, it can happen at any time after initiation of therapy. Certain characteristic features that you see on investigations: if you perform an electroretinography, you will get a maximal B by A ratio decrease. For now, just remember this fact. On an OCT, there will be a thinning of the nerve fiber layer of the retina. Perimetry will obviously reveal peripheral visual field defects first, and electroretinogram changes are seen before OCT as well as perimetry changes. So the reason why you have retinal damage which is irreversible in nature is because vigabatrin is a GABA breakdown inhibitor. It doesn't allow the breakdown of GABA. So there is an accumulation of GABA throughout the cells, especially in the cells of the retina. There is going to be a prolonged retinal membrane depolarization, and when you depolarize a cell membrane, there is going to be an influx of sodium and chloride, and along with the sodium there is going to be an influx of water as well. So there is an imbalance of ions inside the retinal cells, and the cells eventually die and burst due to this homeostatic imbalance. Other side effects of vigabatrin are drowsiness, dizziness, as well as psychosis. So these are the visual field changes that you see. At the outset, the first thing that I want you to notice is that there is a constriction of visual fields, a generalized constriction of visual fields. And this is one of the first features in perimetry that you see as a part of vigabatrin toxicity. Other more characteristic features but not often seen are bilateral nasal wedge defects, which further progress to concentric bilateral field losses. But the first thing that happens is a constriction of visual fields. Certain other anti-epileptic drugs that produce ocular side effects. Diplopia is caused by carbamazepine, lamotrigine, phenytoin, and fosphenytoin, whereas blurred vision is caused by retigabin. It's one of the newer anti-epileptic agents. So these are the anti-epileptic agents that produce ocular side effects. So the answer straight away is the first option, that is vigabatrin. Second question: topical eye drop and eye ointment need to be administered to a patient. Correct sequence of medication is. So before dealing with this question, the first point that I would like to mention is that AIIMS examination questions are basically image recall questions, are memory recall questions. There is no question bank that the AIIMS university directly releases which we can refer to. So the wordings of many of these questions may differ. If you look at some other source of the same set of questions, you may find the words to be different. But AIIMS is not a examination of words, it is basically an examination of concepts and facts. So although the wordings may differ, the concepts of those questions, the core questions, remain the same. Coming back to the question, so an eye drop and an eye ointment need to be given. So correct sequence of administration is an eye drop followed by an eye ointment immediately, drop followed by ointment 15 minutes later, ointment followed by drop immediately, and ointment followed by drop 15 minutes later. So basically this question has got nothing to do with ophthalmology. It is more of a pharmacology question. The concept that you need to understand is that an ointment is an oil-based chemical, whereas a drop is a water-based chemical. If you try to apply water after oil, it is like pouring water on a pan which has oil on it. The water is just going to roll off. The water will never come in contact with the pan. It will simply flow off. Whereas oil, which is applied after water, and if the water is already absorbed, say for example there is a sponge that you have, you place a drop of water on the sponge. If the water is getting absorbed by the sponge, you can apply the oil, and the oil can still come in contact with the sponge. So that is the concept of applying eye drop before eye ointment. So you put a water-based chemical first and then an oil-based chemical after the previous chemical has been absorbed. So whenever two formulations, an eye drop and an ointment need to be administered, always give the drop first and then the ointment after a certain period of time. So how much time? It is usually said to be 15 minutes because that is sufficient time for the drop to get absorbed into the eyeball. Any topical medication that is used, a topical eye drop, 50% of that drop gets absorbed systemically either through the conjunctiva or through the nasal mucosa. So how does it reach the nasal mucosa? It gets drained by the nasolacrimal duct, by the tear system. Only 10% of the drug is available for ocular function. The volume of the conjunctival sac is 30 microliters in all, and one drop is about 550 microliters. So for each drop, say for example, if the patient needs to be dilated by the use of tropicamide plus phenylephrine, a single drop is sufficient because it more than satisfies the conjunctival sac volume. So it doesn't make sense to put multiple drops just so that you hope that the dilatation of the pupil may appear faster. That is not the case. A single drop is sufficient because the conjunctival sac volume is much lesser as compared to one single drop. So straight away the answer is option number 2. You give an eye drop followed by an ointment 15 minutes later. Question number 3. All of the following statements about cornea are true except consist of a stratified squamous epithelium, regenerative capacity is shown by Bowman's membrane, limbus shows reduced mitotic activity and shows microvilli. So for this you need to know the anatomy of the cornea and the histology of the cornea. So look at this image. The part labeled as serial number 1 is the epithelium, which is 50 microns thick. Second comes the Bowman's layer, which is 10 microns. Stroma, which is the thickest layer, constitutes 400 microns. Between the stroma and the Deschamets layer is a newer layer which is called Dua's layer. It was actually identified by an Indian origin ophthalmologist, Dr. Harminder Dua. So the Dua's layer occurs between the stroma and Deschamets, which is about 15 microns thick. Deschamets is the toughest structure of the cornea, which is 10 microns, and endothelium is the most metabolically active, which is about 15 micrometers. So let us look at the epithelium in a more detail because the question is asking about much of the characteristics of epithelium. So the epithelium is a stratified squamous non-keratinized epithelium. So when I say stratified, that means there are multiple layers. So there are 5 to 7 layers in a corneal epithelium. The superficial most cells are flattened cells. Middle cells about 2 to 3 layers thick are called the wing cells, and the innermost layers are the largest, which are the columnar cells. So as you come to the surface of the cornea, the cells become smaller and smaller and more flat. The microvilli are present in the superficial layer, and these microvilli function for tear film stability and adhesion. They help to adhere to the tear film and maintain a uniform layer. So option number 1 and option number 4 are obviously correct because that pertains to the anatomy. Now classically, the only 2 layers of the cornea that have been shown to regenerate are the epithelium and the Deschamets membrane. Bowman's membrane has been said to not regenerate, but there is recent evidence available that shows that even Bowman's membrane may regenerate along with the epithelium and the Deschamets membrane. Option number 3 says limbus shows reduced mitotic activity. So that is absolutely false because we know that at the limbus there are the limbal stem cells that are present, which are responsible for production of the epithelium of the cornea. So option number 3 is absolutely wrong. Limbus shows reduced mitotic activity. It is actually the place where maximum mitotic activity is present because of this limbal stem cell activity, and all the other 3 options are true. So Bowman's membrane is still experimental. So between option number 2 and 3, option 3 is absolutely false, whereas option 2 is relatively false. So you have to choose one option. Option 3 is the right answer. Question number 4, it talks about optics. If numerical aperture of objective lens of operating microscope is increased, which of the following will increase? Resolution, contrast, magnification, or operating distance? So here I want you to look at the optics of an operating microscope. I just want you to look at the structure which is second from bottom, which is the objective lens. When I say I am increasing the numerical aperture of any microscope, I am actually increasing the light gathering ability. So numerical aperture deals with the light gathering ability of the eye. More the light gathering ability, more is the resolution of that microscope. So what do I mean by resolution? It is the minimum angular distance which 2 objects need to be separated for them to be seen as 2 separate objects. So when I say numerical aperture, I am basically dealing with the resolution. Contrast of a microscope is increased by increasing the illumination of the microscope. So here, when I say numerical aperture, I am basically dealing with a resolution. If I increase the numerical aperture, the resolution will also increase. Contrast, as I've said, deals with illumination. For magnification, we do not utilize numerical aperture. There are separate magnifying lenses that are available on an operating microscope, and operating distance will not change despite the numerical aperture changing. So the answer is option 1. Fifth question, IOL formula used to calculate power in post-LASIK surgery is? Again, another fact-based question, but very interesting. Let's first look at IOL power calculation. The classical formula that we use is Sanders, Retzlaff and Kraft, which is also called SRK formula. Here you have to understand, this formula was calculated for a normal axial length, which was about 22 to 24.5 millimeters. And the formula was P is equal to A minus 2.5 L minus 0.9 K. So P is the power of the IOL that is required. A is a constant, which is constant for every lens and varies from manufacturer to manufacturer. L is an average of the axial length of the eyeball, and K is the average of the keratometry readings. So a lot of errors starting coming up because it was assumed that all eyeballs are of normal axial length, but when it was found that there could be axial lengths beyond 22 and 24.5, that is when the formula had to be modified. So an SRK2 formula was brought up. Until now the A constant was literally constant, it had not been changed, but here the A constant was modified, and this modification was done on the basis of the axial length of the eyeball. If the eyeball was less than 20 millimeters, whatever value of the axial length was there of A, the A constant was there. Say for example, if the A constant was 120, then if the eyeball was less than 20 millimeters, the A constant was increased by 3. So instead of 120, you will have 123. And this makes sense because if the eyeball is smaller, then the power of the IOL has to be greater to focus the same amount of light by the same distance. And the reverse is true. If the eyeball is longer, then lesser power is required. So for a higher IOL power, you need a higher A constant. For a lower IOL power, you need a lower A constant, because that is what the formula is. P is A minus 2.5 L minus 0.9 K. So for higher P, you need a higher A. Similarly, if the if the axial length is 20 to 20.99, then you add plus 2. If it is 21 to 21.99, you add plus 1. If it is in the normal range, which is 22 to 24.5, no change in the A constant is required. Whereas if the eyeball is greater than 24.5 millimeters long, then you have to subtract 0.5 from the A constant. A further modified SRK2 formula was made. This was found to be even better than the original SRK2 formula. Similar concept, just that the values of A constant have changed. Less than 20 millimeters plus 1.5 is added. 20 to 20.99 plus 1 is added to the A constant. 21 to 21.99 plus 0.5. Again, if it is in the normal range, then no change in the A constant is required. If the eyeball is 24.5 to 26 millimeters, minus 1 has to be added, which means 1 has to be subtracted from the A constant. So if it is 120, it now becomes 119. And if it is greater than 26 millimeters long, then 1.5 is subtracted. Certain special conditions where special formulae are utilized. You need not know the actual formulae, just the names are sufficient. Less than 20 millimeters long, a Holiday 2 or Hoffer Q formula is utilized. 20 to 22, Hoffer Q is again the best formula that can be used. 22 to 24.5, which is the normal axial length, SRK2 or modified SRK2, Hoffer Q or Holiday 1. 24.5 to 26, Holiday 1. More than 26, a formula called SRKT formula has been utilized. There are more factors than axial length, than A constant and keratometry readings which are utilized in these formulae. Piggyback IOLs, which means a second IOL implanted over an originally implanted IOL. Holiday's refractive formula is utilized. And lastly, myopic LASIK. Any patient who has undergone myopic LASIK, you will use a formula called Haigis-L formula. So the answer here is option number 4, Haigis-L formula. A post-LASIK surgery, Haigis-L. Question number 6. Mydriasis in scotopic conditions is not seen in. So by mydriasis, I mean dilatation of the pupil, which I will not show dilatation of the pupil in dark conditions. So totally blind eye, Adie's pupil, Horner syndrome or Argyll-Robertson's pupil. So let us understand what each terminology means. In a totally blind eye, the retina is not reacting to light. it will not react to light, hence there will be no constriction of the pupil because the light reflex pathway is now abolished. And the converse is true. If light is shut off from the retina, that is when the dilatation begins. So if the light was not stimulating the retina in the first place, then there will be no dilatation at the end of cessation of light. So if there is an absence of light reflex, the pupil is going to be constantly dilated. So whether it be in a scotopic condition or in a photopic condition. When I say scotopic, it means in darkness, and in photopic, it means light. So in either condition, a totally blind eye is going to remain dilated continuously. It is never going to constrict because the pupil will never react since the retina is damaged. AD's pupil is basically a denervation to the sphincter pupillae, which means the parasympathetic nerve supply is interrupted. So consequently, if the parasympathetic nervous system is interrupted, the parasympathetic is responsible for constriction of the pupil. So sympathetic overriding will happen, the sympathetic nervous system will dominate, and the pupil will be in a constant state of dilatation. So there will be a large and irregular pupil regardless of the lighting condition. Whether it is dark or light, the pupil is going to remain dilated because the parasympathetic nervous system itself is damaged. Horner syndrome, there is an exact opposite situation where there is a sympathetic nervous system blockade. So when sympathetic is blocked, that is when the pupil will remain in a constant state of constriction. There will be a tonically constricted pupil and it will be poorly dilating. And finally, Argyll-Robertson's pupil, the pupil basically accommodates but doesn't react to light. So which means near reflex is present, but it does not react to light. So initially there is a sluggish reaction to light, and later on it is completely abolished as the disease progresses. It is classically seen in a case of neurosyphilis. So here the answer is Horner syndrome, because for mydriasis, for dilatation of the pupil, there has to be an element of sympathetic nervous system, because it is the sympathetic nervous system that dilates the pupil by acting on the ciliary muscle. So if that is abolished, if that is damaged, then mydriasis will never occur, whether it be scotopic or photopic condition, whichever condition it is, the pupil will never dilate because of a damage to the sympathetic nervous system. So that brings us to the end of conclusion of AIIMS discussion for this June session. Let me know if I've missed any questions. We can discuss it in the comment section. You can personal message me on one of the few social media platforms. If you like our teaching method, make sure you give us a like on the video, subscribe to our channel, and also follow us on Instagram, where we keep posting image-based reviews. If you do not like our method, please give us suggestions so that we can improve. Thank you for listening. Thank you for watching. Please stay safe. Good day.